Hello everyone and welcome to Conceptual Surgery, and today we'll be talking about examination of the arterial system of the lower limb. I am Professor Anubhav Vindal. Now this topic is important because in case of peripheral arterial disease, peripheral vascular disease, whether it is atherosclerosis, whether it is diabetic foot, whether it is Burgess disease, it's very common to be given in the exam, whether it is MS exam or whether it is DNB exam. And also from MRCS point of view, it is an important topic. And even if you are planning to attempt NEET PG, this is a topic which you cannot afford to miss. Whenever a case of peripheral vascular disease is given to you, the examiner expects you to take relevant history, perform the relevant examination, offer a possible differential diagnosis, and then they will ask you what are the investigations that you would like to do. And out of these investigations, and a very important component of these investigations, which is also sometimes called as an extension of the clinical examination, is the imaging which is done. And finally, with adding of history examination and the information by these investigations, you should be able to give a diagnosis and offer treatment to the patient. Now, the arterial disease of the lower limb can present in two different and distinct forms. One is a chronic form or chronic limb ischemia, and the other one is acute limb ischemia. Now, in the exam, most of the cases, 99% of the cases that will be given to you of arterial disease of the lower limb will be chronic arterial limb ischemia. So, my talk here, my lecture here will be confined mainly to the chronic presentation of limb ischemia. Out of all the patients suffering from chronic limb ischemia, 1 in 2 patients will be asymptomatic. And out of the 50% of the remaining patients who are symptomatic, 40% will present in the form of intermittent claudication. The rest 10% of the patients will have florid and advanced disease, which is known as critical limb ischemia, which can present in either rest pain or obvious tissue loss in the form of gangrene, ulceration, or self-amputated or auto-amputated part of the limb. Now, let us talk about the first presentation, which is the most common presentation in these patients, which is known as intermittent claudication. What is intermittent claudication? So, basically, claudication means limping from pain. So, claudication can arise primarily due to an arterial cause, or due to a venous cause, or due to a neurogenic cause. And it is your responsibility as a doctor to find out which out of these three reasons is responsible for the patient's presentation. So, what is specific about arterial claudication? It is a cramp-like pain which is aching and which is confined to the muscles which are ischemic. So, it will never be present throughout the limb. It will not be present as a generalized pain. The patient will be able to pinpoint as to the site where this pain is present. And then these three characteristics. So, if the examiner asks you what makes you think that the patient is having claudication, you will have to say, sir, the pain is brought by exercising that group of muscles. So, it is not present at rest. It will be present only when that particular group of muscle is made to work. Once the patient takes rest and the muscle is at rest, after some time, the pain gets resolved. Third, a similar activity of the same group of muscles will bring the same character of or the same type of pain back again. So, these are the three things. One, the pain is not present at rest, but it is brought out by exercising that muscle. It is confined to that group of muscle. It improves with rest. It can disappear or improve with rest. Third, it can be reproduced by doing the same activity again. So, this table gives you a differentiation between the arterial, neurogenic and venous claudication. So, arterial claudication onset is never present at the beginning of the first step, and it is a gradual pain because of the pathophysiology that this pain is brought about by the mismatch between the oxygen demand of the muscle and the oxygen supply because of the narrowed artery. So, it is a gradual pain which will build up like a crescendo, decrescendo pain. Once the pain is severe enough so as to force the patient to take a rest, the patient will take the rest. The muscle's oxygen supply demand will go down, and at the baseline again the supply and demand will match and the pain will go away. In contrast, the neurogenic claudication pain is because of the entrapment of the nerve at the neural foramina. So it will be present right at the first step. Even when the patient has not taken the first step, has even stood up, the pain may start then. And in fact, it may improve not by taking rest, but by bending or by alteration in the posture or by lying down. The venous claudication pain is again gradual, but it does not happen after some time. It will start soon after walking, it will build up, and it will then force the patient to take rest. And just by taking rest will not alleviate the pain. In fact, the patient will need to elevate the limb in order for the gravity to aid the flow of the blood from the periphery towards the heart in order to alleviate the pain of venous claudication. The pain in venous claudication is more of a bursting kind of a pain rather than an ache which is present in arterial claudication. Now, if the patient gives you a history of intermittent claudication, you need to find out what is the severity of the pain that the patient is experiencing. And for this purpose, there are several grading which have been described. One is the Boyd's grading, which classifies the grades into 1, 2 and 3. One where the pain, if the patient continues to walk, after some time the pain will disappear. But this will be because of reactive vasodilatation. So, the arterial stenosis is not severe enough so as to curtail the inflow of blood. It does curtail some amount of inflow, but because of the reactive vasodilatation brought on by ischemia and the metabolites produced by the metabolism of the exercising muscles, there is reactive vasodilatation, there is increase in the blood flow which washes away the metabolites which are producing pain, and when the patient continues to walk, the pain goes away. So that is grade 1. Grade 2 is the pain happens, will increase, and it will be severe but not severe enough so as to cause the patient to stop walking. The patient will be able to walk with pain by making some additional effort. The third will be the pain is so severe. So this is all a progression of the disease. It is all a continuum. In grade 3, the pain will be so severe that the patient is forced to take rest. So after intermittent claudication, the next higher level of presentation is critical limb ischemia, which can present, like we discussed, either as ischemic rest pain or as tissue loss. So ischemic rest pain, as the name suggests, it is a pain which is present at rest. And it is usually present not at the level of muscles, but in much more distally in the forefoot at the level of metatarsal heads. So the ischemia is so severe that the demands of the foot are not met even in the resting position, even when the muscles are not exercising. It usually occurs at night because of 3 reasons. One, the patient's mind is at rest, so the patient is more aware of his pain. The heart rate is usually less and the BP is also decreased. So this all decreases the inflow of oxygen in the blood to the peripheral tissue, which aggravates the ischemia and makes the patient more aware of the pain. As a result, because the pain is more appreciable at night, many a times the patient learns to sleep while sitting, because dangling the foot out of the bed or keeping the foot vertical will aid some flow of blood down with gravity, which might decrease the amount of ischemia, which might aid the delivery of oxygen to the periphery, and which may decrease the pain somewhat. The pain is so severe that it is not alleviated by normal analgesics, over-the-counter drugs, and the patient often requires narcotics for relief, and many of these patients become ultimately addicts of these narcotics. And the classical description of ischemic rest pain is that it is the cry of dying nerves. The pain originates not from the deeper structures but from the somatic nerves, because the ischemia is so severe that the metabolic demands of the skin and the nerves supplying the skin are not met. The second way in which critical limb ischemia presents is tissue loss, which can be in the form of either gangrene or non-healing ulcer. And like rest pain, it will also occur not at the level where the muscle